Good morning, all. So today I'm going to talk about the first of its kind, the simulators in regional ophthalmic anesthesia. Where were we? As you all know, in healthcare, we have simulation for endotracheal tube intubation, for doing basic life support, for starting central line, peripheral venous cannulation, and even for cataract surgical steps, we do have that healthcare simulation. But for ophthalmic regional anesthesia, this is the first of its kind which we have developed. First, we developed in 2015 a simulator named Ophthalmic Anesthesia Simulation System called OASIS. In this, the simulator objectively grades the participants whosoever blocks the mannequin. But then later on, we got some interesting feedbacks from the participants. One is that inability to view the ocular structures and the needle track pathway. And the second information which we got is whether the visual feedback about the free space that is available within the orbit, and also whether the angulation depth of the needle inserted shown can enhance the training experience. Based on this, what we did was we placed two cameras, one at the inferolateral wall and other at the medial wall in the mannequin, and hereby we are able to see the needle track also. This is the lateral view, and here we can see the needle very clearly. This is from the lateral view, and you can also observe that globe, optic nerve, and the extraocular muscles. This is the medial view, and once again we can clearly appreciate the needle here just between the medial orbital wall and the globe. Now, before going into the detail about the simulator, just wanted to briefly update you all about the recent update in regional ophthalmic anesthesia. That is, traditionally the block says you should enter at the medial 2/3 and lateral 1/3, and then the supplementary block should be at the superomedial quadrant. But half late, what is the safest site for performing this regional block, they say, is extreme inferolateral corner, that is just above the lateral wall and the floor. You should enter the orbit rather than the medial 2/3 and 1/3 junction. The reason is you can hit the extraocular muscles, thereby resulting in muscle injury and myotoxicity later on. The other safe site for performing the supplementary block is medial peribulbar. Why not superomedial? The reason is the space available is the least there, most vascular, and many globe perforations can occur. So the safest site is medial peribulbar block, that can be the supplementary injection. Now, keeping this in mind, we did a survey that got published recently, and in this survey we circulated a 10-item questionnaire where we want to know what is the preference site of blocking the patients, what was this preference for the supplementary injection, what is the size of the needle they used, and how did they learn the regional ophthalmic anesthesia. So we just supplemented this 10 questionnaire, and nearly 145 trainees participated in it, and experience varied from minimum of 2 years to 7 years. As you can see, around 93% of them still tend to follow the traditional way of blocking the patients, and around 52 to 89% have not performed the medial and subtenon blocks respectively. So these are all some of the results, and many of them seem to doesn't know the size of the needle also, what they are using for performing the blocks, and type of the bevel, whether it is a sharp end or a blunt one. And the most scary thing is about nearly 85% of them still tend to follow the superomedial block as the supplementary injection. And another interesting information which we got was how they learned the performing the blocks. As you can see, many of them are just observing the seniors and then they learned the blocks. And many of them were reading books, some of them by attending conferences and lectures. Unfortunately, there are no simulators to practice on this regional anesthesia. So finally, we concluded that present study shows the trainees still follow traditional way of block, and the current teaching needs an immediate change, involve hands-on practice session on simulators and animal models. Now, with this as a background knowledge, we developed this real-time view mannequin where we can see the participants performing the blocks in the simulators, and at the same time they can also view the system, how they perform the blocks, the needle track, everything we can teach the participants. Now, some of the technical highlights, how we made this simulator: the globe with the extraocular muscles in the orbits which mimics the normal globe orbit relations, was 3D designed and printed, as you can see in this picture. Then the rubber which was used for the phase 1 was the mannequin facial features or molded using a special type of rubber called OMO 30. Then two high-end definition cameras were placed, as I was mentioning, one at the inferolateral wall and other at the medial wall to show the needle track. Other special features are it provides a human analog replica of the normal globe, extraocular muscles, optic nerve, intraorbital space and orbital wall, which helps the participants to learn the anatomy as well. It also provides the ability to visualize the needle track pathway and also ability to see the angulation and how much the needle can be inserted into the orbital space. And finally, it has an inner video screen recorder also, which helps the participants to go through back and correct the techniques accordingly if they had made any mistakes. Now, there were some limitations. One, we made only normal human globe and orbit relations. We are not mimicked an abnormal globe orbit like deep set eyes or forward set globes or myopic eyes. So future, we are trying to integrate these abnormal globe orbit relation conditions, and also we will try to simulate major vessels which were lacking in this simulator, like ophthalmic artery and venous plexus also in this mannequin. To conclude with this needle simulator, this type of training system by providing visual as well as physical feedback is novel in ophthalmic anesthesia training, can be utilized as a teaching module, and it can enable many to train them to administer a safe regional anesthesia in their patients. Now, the second simulator which we developed was the subtenons simulator. This was a real challenge for us because unlike needle block, here the participants has to make a nick in the simulator. So it is a little bit invasive. So this was a real challenge for us, but fortunately we were able to do it. As you all know, the subtenons is gaining popularity now, and they say it is safer. But still there are some major complications can occur, as I was mentioning here. It can result in orbital and retrobulbar hemorrhage, globe perf, and central spread of local anesthetics is also required. It requires a thorough knowledge, practical skills, and anatomically accurate training and evaluation system is needed. Unfortunately, there was no training system available so far for practicing subtenons block. With this as a background knowledge, we developed this mannequin for practicing subtenons block. Some of the special features are, totally we made 4 parts. One is mimicking the eyeball, the other mimicking the tenons and the conjunctival membrane, and the third one was the optic nerve. These are all prepared using platinum cured silicon based rubber. It's a special kind of rubber which anatomically accurated eyeball with replaceable conjunctiva and tenons membrane were made. Now, once these were made, around the eyeball, the tenons and the conjunctiva were wrapped up, and then at the other end, we just tied the rubber band, and then optic nerve is then fixed behind. Then we made a specially designed eye holder where we kept that eyeball in it. The advantage is that once, as you can see here in the side, once if the participants has made any dissection, we can rotate the eyeball so that the undissected part can be used for performing the second and subsequent injections. Like this, a single membrane can be used for performing about 5 to 6 blocks in it. Okay, so that is one of the advantage with this eye holder. We are able to rotate the eyeball easily. Now, others this simulator can perform is that it can detect the quadrant of entry, in which quadrant the delegates enter. It can detect. This is by the technique of magnetic sensors, where we have placed as a magnet. Unfortunately, this is not working. Pointer is not working. We have placed a magnet here in the syringe, and the magnetic sensors is placed at the, thank you. So here we have placed a magnet, okay, at the syringe, and the magnetic sensors are placed at the here at the eye holder, magnetic sensor. So in this way we are able to see in which quadrant the delegates are entering, whether they are entering into the superomedial or the inferolateral, etc. Also, this simulator can detect the plane of entry, whether they are entering into the wrong plane, that is the subconjunctival plane, or into the correct plane, that is the subtenons. If they are entering into the correct plane, that is subtenons, then a green light will come. As I will show a small video here. Here they are making a nick, okay. using the conjunctive. This is done in the IIT lab, so that is why the surrounding is full of electrical equipments, and this is not an hospital setting. So you can see the green light is glowing because if they are in the correct plane. This is by the mechanism called as capacitive touch sensing method. Can you just meet it? Just 2 more minutes, please. So the eyeball is made conductive by mixing copper chopped fibers in that eyeball. And if the cannula is in the subconjunctival plane, what will happen is that the cannula will not come into contact with the eyeball, which is conductive. Hence, what will happen? Red light will glow. Whereas, if it is in this correct plane, what happens? The cannula touches the eyeball or very near to the eyeball, then it is been a conductive. What happens? The green light glows. This is how the mechanism we kept it as. So we then compared this with the traditional way of learning that subtenons block. As of now, we are learning with the help of goat's or pig's eye. So we did a small comparative study, which was best, and we divided into 2 groups, and we found that most of them were preferring our human this simulator. The reasons is ease of usage, warning systems was there, no bio waste, and it is repeatability. As you can see, animal model, that is the goat side, does not offer facial anatomy, needs a qualified instructor, it needs time for replacement, it needs the things to be disposed of properly, the goat's eye I mean, needs gloves, aprons, etc., hand washing facilities. Whereas our simulator model, it provides training environment closer to the clinical setting, shorter time for the replacement of the eyeballs. The eyeballs need to be actually replaced with the membranes, and it requires shorter time only. But there were some limitations. One, vessels were not replicated, membranes need to be replaced after 4 to 5 pricks. In future, we are trying to have some abnormal conditions also, myopic eyes and staphylomas, and this will definitely help to learn and practice safe orbital regional anesthesia. Can give a hands-on practice session also, train the paramedics to administer blocks to learn and teach anatomy. To conclude, this is an effective anatomic analog for learning subtenons block. These are all some of the publications we made. This is the one which we did for the evaluation of the needle blocks, and this is one publication for evaluation of the subtenons block, and these are all some of the workshops which we conducted with for the delegates. Just want to make a small announcement that there will be 7th and 8th of October, we are having Association of Indian Ophthalmic Anesthesiologists National Meet at the Hyderabad. Center for Sight will be organizing. I welcome you all for the conference. Thank you.